Alright, so overview, always like to start with this one. Some of these little cartoons, have you seen them before? I love them. You have to be careful with some of them, the language is totally inappropriate. But this one I've seen a gazillion times, so we'll sort of start off with this. And you will see this patient in the ER multiple times. Oh, I need to plug the speaker in. Hang on.
Good morning, ma'am. My name is Dr. Campbell. I'm an emergency room physician. What seems to be the problem?
I have a horrible headache. Oh my God. It hurts.
Do you have a urologist? Do you have any allergies to medications?
I'm allergic to Tylenol, Toradol, Motrin, Ultram, Zofran, and all over-the-counter medications. I have taken a medication before that really helps. I think it starts with a dilaudid. That's it. It's dilaudid.
I'm not going to give you any dilaudid.
Oh my God. My head hurts so bad. I need dilaudid, 4 milligrams of dilaudid and 25 of Phenergan. It only works if you push it fast. No buffer, please.
I'm not going to be giving you any narcotics today. I would be more than happy to check you in and work you up. I think we should get a CAT scan of your head. I will not be prescribing any narcotics though.
Fine. I need a Diet Coke, a lunch tray, and a TV.
Of course you do. We will get you taken care of.
If I don't get any narcotics, I will not be paying my hospital bill. Just letting you know. Now, go and get me a turkey sandwich.
And you definitely can't make it up. It happens all the time. People come in the ER for their drug seekers. They come in for drugs. Okay, Dilaudid, because you don't know this, it's a very powerful narcotic. You give me that much Dilaudid, you could wake me up next Friday. And then Phenergan is a promethazine. It's this other name for it. Phenergan is for nausea and vomiting. But Phenergan potentiates the medication, or what it does is it makes it seem like it's stronger. Okay, narcotics typically makes the patient nauseated, so they give them something for the nausea. All right, if you gave me 12 and a half of Phenergan, I'd be out for the weekend. I mean, I wouldn't wake up. Lay me back there and wake me up on Monday. Okay, but anyhow, you'll see these guys. Once you see it, then you'll think back to the little cartoon. You go, oh yeah, that person. Okay.
Are they aggressive sometimes?
No, they're just seeking drugs. And then, so let's look at this. This is what we're going to talk about through the time. Chest pain, which today, congestive heart failure, probably won't get to today. That's pretty lengthy. Respiratory problems, emphysema, chronic bronchitis, pneumonias, asthmas, okay. Altered mental status, there's a gazillion things that could cause altered mental status. One, a urinary tract infection can cause altered mental status, a big time altered mental status. What do we do with anybody that has an altered mental status? Randy's rule for altered mental status, what is that? I think we spoke of it. Prick the finger, blood, initials BGL, blood glucose level. Now the memory comes back, right? Okay, blood glucose level. Anybody with an altered mental status, we can always check a blood glucose level. Keep that in mind, okay? Always responsible for the information. Anyway, anaphylactic shock or anaphylaxis, allergic reaction. heat emergencies, cold emergencies. All right, these are things that we're going to look at. Alcohol and drug emergencies, and then OB is towards the end. Teach you guys how to deliver babies and some of the complications in delivering babies. Hopefully, by the time we get there, you guys who go to labor and delivery have already seen it, so you'll live it. If not, then we go to the other school. They have a mannequin that delivers a baby. It's pretty cool. We'll go over there without the smell and liquid, so you miss out on that. But anyway, every time that we do the medical, any sort of medical problem, we assess the patient assessment, right? We're making an assessment on what's wrong with the patient, okay? We determine their chief complaint, which is abbreviated, I believe we've talked about this, C/C, chief complaint, okay? And this is what the person tells you. So, this lady in the cartoon, her chief complaint was, I want drugs, okay? So, or my big toe hurts. With documentation on the chief complaint, you put that in quotes because it's what the patient tells you, okay? The following signs and symptoms is what they're complaining of. So let's say they're complaining of chest pain.
We have an MISD van that is parked in the back of the building where the van is trying to park their 18-wheeler. We need you to move it, please. There's an MISD van parked in the back of the building where the van is trying to park their 18-wheeler. We need you to move it, please. Thank you.
So if the patient's chief complaint was chest pain, and that's abbreviated CP, not that you want a CP, but chest pain, right? Little Friday urinary joke for you. Okay? So the complaining of would be the following signs and symptoms supporting the chief complaint. So shortness of breath, not the SOB that you're thinking of, right? All capitals, S, shortness of breath, okay? Nausea, vomiting. So these would be supporting signs and symptoms. Remember that a sign is something that can be measured or seen. So vomiting is a sign. Shortness of breath is what the patient tells you, and it is a symptom. Right? You can't see shortness of breath. Now you might be able to see the use of accessory muscles and things like that when we get to respiratory, but not shortness of breath. It's a symptom. Right? And then we base everything on the signs and symptoms. So whatever the patient's chief complaint is, we base our questions and we base our treatment on signs and symptoms. The same way that you go to the doctor. You tell the doctor, my throat hurts, would be the chief complaint, right? It feels like I'm swallowing razor blades every time I swallow spit. Okay, that's you're complaining of excruciating pain when you swallow spit, right? They look in the back of your mouth and they see all these white pus pockets. And they go, oh. And then they happen to smell your strep breath. And they go, woo, you definitely have strep. We don't even have to test it because your breath smells like a turd. Because you have strep breath. So they're basing their on signs and symptoms. Now they're going to confirm it by taking a swab in the back of your throat, doing a quick culture of that, okay, and say, yeah, that's strep. You know, don't want that. So it's based on signs and symptoms, things that we look at, common things, altered mental status, AVPU, right? We check the AVPU, remember AVPU? And then also we check the level of consciousness or the by person, place, time, and event, right? So this is what we're checking there. We look at the rate. Anytime that when you start evaluating your patient, you will remember this because it's very important. You always look at the rate, and that would be the heart rate, okay? Rhythm, the cardiac rhythm, what rhythm are they in? And then and blood pressure. Rate, rhythm, pressure. Remember those three words. That won't change, because the fact that the heart rate will tell you so much. The body compensates a lot of times by speeding up the heart rate, right? And then we look at these others. You notice that, and we talked about this in shock, correct? That the blood pressure is the last thing sort of to go. The body's going to compensate. So we look at this rate. Said tachycardic above 120. You know, tachycardia is above 100, right? But is it above that 120 mark? That's sort of getting really fast for an adult. We're only speaking of adults here. And so, or below 50, which produces, we'll learn here shortly, that either way, it's going to decrease cardiac output. If the heart rate is too fast or too slow, it has a decrease in cardiac output. And we haven't got there. We'll get there. Okay? Breathing rate, less than 8. All right? When a person hypoventilates, right? Hypo, low, they retain CO2. And so they become acidic because they're breathing too slow. Greater than 24, what are they doing? Somebody said what? Hyperventilating, which does what to the CO2? Yeah, well, it's too much of the CO2 off. You have too little CO2. That doesn't seem like a bad deal. You have too little of the bad gas, right? But we have to keep that balance. 35 to 45 is the normal CO2. So we have to keep that balance. Either way is bad. What's the normal skin supposed to be? Warm, pink, and dry. So we look at that. We look at the color of the skin. All right. If someone was to notice on Wednesday, right? Did anybody notice except me?
Yeah.
The paleness of her skin? No?
Yeah, I remember.
Nobody? Yeah, you noticed? Right? That's what pale looks like. I wanted to take a quick picture, but man, it might be a little inappropriate at the time. But, you know, because we have to know what that looks like. What does pale look like, you know? That was pale. All right? No big deal, but that was pale. All right? Color of the skin, temperature, should be warm, shouldn't be clammy. You guys want to know what clammy skin feels like before you get to the hospital? That's why we touch people when we go to the clinical sites. They say, oh, they're clammy. Touch them so you can feel that tactile. You remember that. You use the senses and you have the tactile stimulation, right? Boil some noodles, okay? Cool them off, and then stick your hand in. That's clammy.
What?
You touch that, you go, ooh. But that's clammy. And then are they sweating or diaphoretic? Diaphoretic's the medical word for sweating. If you need to know the spelling, ask Google. Dia, D-I-A, for P-H-O-R-T-I-C, I think. But you don't know to be accountable for spelling. Diaphoretic. So you look at that. Pupil size and response. You know, when we shine the light in the pupil's eyes, it's supposed to constrict, right? And then dilate back to its normal size. We're looking for pearl. There could be an extra R in there for round. I don't use it. I just use pearl. But the pupil's supposed to be round. Pupil's equal and reactive to light. Breath odors, right? But back to pupils just for a second. It's going to tell you a lot about the neurological function, okay? About other things, overdoses, different things, okay? Breath odors, not coffee breath odor, but, you know, strep. Just use that example for strep, right? Other things that you would see, people with diabetic emergencies that are hyperglycemic, hyper, right, above, glycemia, the GLY in there for glucose, right? High blood sugar, they produce they can produce ketones. It's burning that fatty acid off, which produces the ketones, okay, and it smells sweet. Has sort of an acetone smell to it. A lot of people think it smells like bourbon. You know what bourbon smells like? Oh.
Is it cute?
You're going, no. It's the same question you get. Smoke? Oh, smoke. Right? But bourbon, sort of a sweet smell to it. It's whiskey, all whiskey has it. But the sort of the sweet smell, I'm not bringing any to class for you to smell. For you to smell that, you have diabetic patients come in the hospital that are producing ketones, okay? And you'll smell that, and you go, okay. And you'll know, oh, that's that smell. I've brought everybody into the one room before. Patients altered so they didn't know it. And I said, take a breath. Smell that. Smell those ketones. Okay? And that way you're using another sense. Smell, tactile, touch, smell to remember these things. Oh, ketones, diabetic, diabetes, hyperglycemia, right? Plus they will lead you to some conclusions. The other one, abdomen, soft, non-tender, correct?
I'm sorry.
That's good.
For diabetic emergencies, what if their blood glucose level is too low? Would it still smell the same? Or
No,
would
they
it
wouldn't be
smell
burning ketones. Then I don't believe. Possible. It depends on the situation, but I would say no right now. We don't hold you to that. Okay. Hypoglycemia would produce often mental status, unconsciousness. I'm not really sure about the ketones. Hypo. I've always smelt them with hyper. But tenderness, rigidity of the abdomen is supposed to be soft, non-tender, correct? Spasms, paralysis. This is talking, put a slash right there in your notes for seizures. This is what this is talking about. Bleeding or discharges from the body. Okay, there's a lot that goes into that we'll look at. That tells you a lot. All right, they're having these discharges. They're bleeding. One of the worst smells on my list, okay, is a GI bleed, a lower GI bleed. Blood and poo never mixes well together. You will never forget the smell of a GI bleed. You can smell it. It fills the whole space, the whole room, the whole floor. You can get off the elevator on the second floor and go, somebody has a GI bleed. And you can just follow your nose to that room. As you get closer, it gets stronger, right? So, again, using that sense, you smell that. Once you smell a GI bleed, you don't forget that smell, okay? And then, then it recalls, it helps you recall the information once you see it and once you take care of it, okay? That's why it's so hard right now if you guys were to put this information, concrete this information down. You don't have any examples, live examples. But that's about to change. Alright? Pain's a weird thing. Sometimes we take pain medicine to actually numb the pain. Other pain medicines actually trick the mind into telling you that you're not in pain. Alright? Pain is one thing that we can see in pain. If they're tachycardic, if the patient's tachycardic, they could be in pain. And that they could be in pain even though they're unconscious, unresponsive. If they're tachycardic, they could be in pain. You can feel pain being unconscious. Okay? Temperature, fever, chills, okay? They feel cold because they have a fever, right? Keep this in mind. Like a good example for a fever is that, you know, a normal fever is 98.6 or 35 degrees Celsius, right? So if you're warm, so you get into that nice warm shower and you're taking a really good, nice warm shower and steam's going up everywhere, right? And it's probably really hot in there. You open the shower door and you step out into your 70 degree room. Woo, right? It's cold in here. Okay, same principle. Body temperature goes up, which makes the external environment feel cold. But we don't put blankets on patients with fever. It will only raise their body temperature. Maybe a thin sheet, but not a blanket. They'll be asking for a warm blanket, but we won't give it to them, right? Because they're running a temperature. Upset stomach, vomiting, a bunch of things causes that. The body pulls blood away from the stomach to use it somewhere else. It auto-regulates. It's an amazing thing that we'll learn about a little bit later more. It will shunt blood or pull blood away. And once it pulls blood away from the GI tract, nausea takes place. Sometimes it's just that QT burrito that you ate. You ate that burrito on the way to school, you know, a Quick Trip, or you know what I'm talking about, or 7-Eleven, maybe closer to here. You went on, oh, I'm starving, I'm running late. Let me get this burrito with eggs in it from 7-Eleven. Really? Okay, and you eat it on the way to school. In time you get to school, you're going, oh, I wish I wouldn't have done that, and boom, right? Yeah. Two things that don't go together. Okay, eggs and fast food or convenience store. Okay, so those little burritos with eggs in it in convenience store don't go together. Okay, I can't tell you how many people I've seen that have some sort of food poisoning or GI distress. They ate the eggs at a gas station. If you're hungry, buy a pre-packaged muffin or something, okay? Stay away from the eggs. Dizziness, feeling faint, a lot of things that can cause dizziness. Shortness of breath. We'll break this down into work of breathing and dyspnea. Dyspnea is difficulty breathing, right? I can spell that one. Maybe. Okay, dyspnea is different than work of breathing. We'll break that down because it's important, but we'll do it later. Pressure of weight in your chest, your abdomen, that's what we're about to talk about, okay? Diarrhea, the inability to retain water, different bladder things that take place. All these are important. Thirst, hunger, taste, burning sensations, okay? Burning sensations when you urinate. Is it a UTI or is it an STD? You know, I mean, you note these signs and symptoms, and you look at that, and we figure it out. They say practice medicine, right? Mm-hmm. Doctors practice medicine. Why do they say practice?
Because every patient is different. So.
Yeah, that's true. But practice leads you to think what? Yeah, but
they're learning.
They are learning. Okay, but practice means that sometimes they start giving you medicine and do things and it doesn't do any good, and then they have to go back and change it because what they were doing wasn't doing any good. They're sort of practicing that, you know. So anyhow, keep that in mind, because you will start doing things in your patient assessment. You're giving these medications and it's not changing anything, and you may have to change the course, something different, you know. Like if you go in with a certain bacterial infection, they may start you on oral antibiotics, right? And that should take care of the problem. But the doctor always will tell you, hey, in 5 days, if this doesn't help, you need to come back. Have y'all heard that before?
Yeah. Mm-hmm.
Well, why don't you just fix it now so I don't have to come back?
Oh,
right? Because they can't. They're practicing medicine. It's a practice. So you may have to come back for a shot, injection or something. Even worse, the patient may have to go into the hospital, right, to get IV antibiotics. So anyhow, these are the different things that we look at. So let's look at this right quick before we take our break. So things that we do, we have an algorithm. In medicine, you always work sort of off an algorithm. Okay, so you do a size up. You're sizing that up, or you're coming to conclusions. Okay, and this is before you make patient contact. All right, so you size this up. Part of this, right under that, okay, is, I mean, you're looking for clues. That's probably the best way to describe a size up. As you approach the patient, you're looking for clues, okay, to what might be wrong. Okay, so you're sizing that up. You're taking in information, okay. Right under that size up, put general first impression. Need to add that in there, okay. General first impression. As I walk towards Steve, I'm sizing things up and I'm looking around. And I'm sizing up and I'm looking, okay, good. Everybody's pencil's moving. That's good. I size that up. So you must, either you're writing a note to your boyfriend or girlfriend, right? Or you're writing down general first impression. I don't know, right? But you're writing something, so it looks fairly good for right now. Does that make sense? You size up. As you get closer to the patient, you're in the patient's room. Now you make a general first impression. What does that look like? Okay? Forever and a day, we're going to use the example probably, okay? As I look over, I'm sizing it up. We're in the cadaver lab. We're about to have a really good time. You know, I can't wait. I'm like a kid in a candy store, okay? You think you were excited. Me was 10 times more. I mean, I could hardly contain myself, all right? To look in that bucket next to me. I really just wanted to flip it open and start looking in it, but it's not my house, right? It's like going in your house and just going straight to the refrigerator, right? Okay, but Katie, as I was sizing up this thing, we were looking around, everybody was like this. I noticed everybody started getting tired, so they got the seats, okay. That's okay. Really, the seats were meant for people that were getting dizzy, but nausea. But anyway, I noticed this lean on the sink. Not something I would do considering what's in that place. Started leaning and then started sitting, right? And then you size up, you make this general first impression. When I look over, I'm like, oh, this is not going to last very long. She's like going down the slope here. So I almost went over next to her, like, no, it'd be more funny if she passed it out. Just joking. Well, that's Steve and I. I'm like, yeah, this is not going to take place very long. She's getting really pale. And then she took the initiative, right? Good job.
That was she.
Good.
You did not notice her?
Right.
You were right next to me, facing her.
Things were going downhill quick, right? So that's what I mean by general first impression. Once you get used to making this, you make it like that. You're going, oh, problem. There's a problem there. Okay? Thanks for being our example. Yes. Don't worry. You're not the first or the last. Okay. So anyhow, so you do your initial assessment after that, which is your ABCs. If they're conscious, their eyes are open, right? Alert to that, you do ABCs. If they're unconscious, you do CBA, right? Circulation, airway, breathing, circulation. So I think he's conscious because his eyes are open permanently now, since I cut them open. So I come over and say, hey Steve, how you doing? And check a pulse. Okay, and Steve says, oh, my chest hurts. Patient's chief complaint, chest hurts. Okay? And this is what we'll learn a little bit later, okay? As we start our assessment process, okay, our sample, or OPQRST, right? As we start that process, we also start our physical exam. These sort of blend together. They do this. And you start asking questions and doing the assessment, they blend together. Okay? That will take a little time. Right? That's nothing that takes place like boom. Alright? Unless you're just super abnormal. Normal people, it takes a little time. Alright? Ongoing. Yes. Try to reassure the patient. Okay? Never give the patient false hope. And very important, treat according to your abilities, or treat according to your standard of care and your scope of care. Remember those two? Standard of care is what?
The rules that are set in place that you have to follow.
Yeah, the easy way for standard care is how you do things. Scope of care, scope of practice is what you can do. Okay, very important to remember that in the hospital setting. Scope of practice. You guys have a scope of practice. It's what you can do. Don't do things you can't do that you're not authorized to do. Okay. Anyway, so as we go through there, all right. So we start talking about chest pain, and when are there any questions here? Because this is a really important step that we have. We want to make sure that you guys are, and as you get better, remember I say as you get better because you will, as you get better and more comfortable with it, you're going to really be good with assessments, okay? But for right now, we just have a systematic approach to it. It's sort of paint by the numbers until you learn how to paint, right? Have you ever did one of those paint with the number things on it? That might be too old for you. You know, number one. You paint all the things with the number 1 on it, a certain color. Then you go to number 2 and you paint all the number 2s, right? That's sort of paint by the numbers, right? Well, as you get better with your assessment process and your knowledge, you won't have to paint by the numbers. You'll be able to go in there and just start painting. And it looks better when you can do that. It looks like, man, if I sat down there and I started painting by the numbers, you would look at me and go, well, you don't really know what you're doing. Okay? But it still looks good, right, at the end. It still looks good. Painting by the numbers. Okay, so the end result is the same. But if you had someone with, I have no artistic ability, but if you had someone with artistic ability and they just sort of go, you know, and started painting, you go, wow, they really know what they're doing, right? It's the same principle that what they do. So this is what we'll spend a lot of time doing this because it's a gift that keeps on giving. Once you learn the assessment, your sharpness may go away a little bit, but it's still there. You just have to sharpen that blade up when you start working. Everybody good?
Oh, okay. So, say that a nurse is doing the patient assessment, and they forget to ask something that we think might be important, but we leave. Do we tell them, or do we just, if they left the patient already?
You might bring it up in a tactful way, right? You might say, in class we learned about this, but I noticed that you didn't ask about it. What? You know what I'm saying? You make it where looks like you're trying to learn, you know, but you're really asking, hey, what the heck, you know, right?